career, I've just been really interested in the patients and families who live here with us. There are patients who undergo heart surgery and they have, a 5-day length of stay, and that's really stressful for families, and that's really important, and I take care of those patients. But it's something different to take care of families that are in and out of the hospital or in and out of the clinic, have hospital length of stays that are approaching months and sometimes even over a year we've had, and figuring out how to partner with those families and support them through that experience and to be a part of their longitudinal journey is really an incredible gift, and I enjoy it. So that is what my clinical focus is. And when you spend time with families who are going through that, you can't help but have some research questions that you want to answer. I guess what I would say about all of that is that some people have a passion for scientific exploration, and I think my passion is patient care, and my QI and research efforts stem from that passion. Throughout the time in the hospital, we try to really stay focused on holistic, comprehensive inpatient care. We focus on supporting the separation from family and friends, which is particularly challenging during COVID. And we try to implement the creative use of technology to bring families together when they can't be together in person. Optimizing growth and nutrition in collaboration with our dietitians. Providing as much developmental therapies and school support as possible, considering that we have, in some ways, a captive audience, and we have a number of individuals who help us with that. We collaborate with Child Life, our Lurie school teachers, PT, physical therapy, occupational therapy, speech therapy, art therapy, music therapy. All of those individuals try to create a comprehensive developmental plan for each kid. We try and support patient and family mental health and identify and screen for social determinants of health that can impact health outcomes as best we can in collaboration with social work and our psychologists. Suddenly, for a while there, we could only allow one parent at the bedside at a time. We're fortunate there were children's hospitals embedded in adult hospitals where basically people weren't allowed to come, or if a parent could come and had to stay in the room with the child the whole time, and if they left, they weren't allowed to come back during the height of COVID, especially in New York. And we were fortunate that we never got that far, but if you're in the hospital for 5 days, it's fine for only one parent to be able to come. If you're in the hospital for a year, that's a totally different thing. And so trying to figure out how to support families but still keep everyone safe led us to really rely on telemedicine. When you do more complex work on diversity, while racial disparities in health outcomes are really important and are real, it's also true that all people come from all different backgrounds, and all of those individual features of a person, a family, a patient affect their outcomes and the way that we interact with them. And so I think we've tried really hard to really better get into the details of that and support those things, both with concrete resources and also just with like sort of emotional support. We're also doing a study. One of our cardiologists, Dr. Brian Wolf, is doing a study looking at the family characteristics and hospital factors that affect the psychosocial outcome. He's surveying parents at 1 month and at 1 year to see, like, is it mostly the medical things that are creating family stress, or is it like all the things around that, your employment situation and how far you have to travel to get to the hospital? Are there other siblings at home? Like, all those real life things that we don't spend enough time thinking about when we're thinking about, we're changing the Lasix dose today, or what are we doing with the ventilator today, when really what may be more affecting the patient and family outcome is real life, and how are we supporting people through that. The study also will look at how parent psychosocial adjustment impacts the baby's quality of life in the long term, because we know that those things are tied together. And frankly, hospitals don't always spend enough resources supporting families specifically. But if we can show more clearly that parent mental health outcomes are impacted by these psychosocial factors, maybe we can improve the resources that we're able to allocate to the family as a whole and not just the patient, if we can show that it really does improve outcomes for patients. From our preliminary results, we know, and also from other published research, that the need for nasogastric tube or G-tube support at discharge from the neonatal hospitalization is a major source of psychosocial stress for families. kids should be out in the snow making snowmen, and they should be at their lake house in Michigan, and they should be going to the grocery store with their moms and dads and not living a life of seclusion just because they have heart disease. If we want them to be successful adults in the long term, we have to let them have those experiences. And so most of my outpatient work is built around how to support families to build the confidence to do that and how to measure whether or not it's okay. And I think one of the next biggest areas that I hope to continue to move into with my own actual research is about exercise. So that is what I do and what I'm passionate about. And thank you for listening.